So once you know the idea of the patient, that what might be patient thinking about the diagnosis, now you know that in which direction you have to talk. Like if patient is ready to hear some bad news, or patient is thinking that it's something like only a chest trauma or something like acidity. So you have to go accordingly. And sometimes patient is having a separate diagnosis like mild costochondritis, but the patient is thinking in the wrong direction because patient is anxious and he or she might be thinking that he or she is having heart attack. So in that case, also you know that what the idea of the patient or the concept of the patient, and then you can reassure and you can give that support to the patient that no, you're not having heart attack right now. uh, the things you told me and my assessment on based on all those things, I'm sure that you're not having any heart attack. So by doing that, you will know that you are giving some reassurance and it will count as your interpersonal skill. I will be telling you that how to sort out the diagnosis when there is a symptom like chest pain. Uh, so once you know that what's the idea of the diagnosis from the patient, and now you need to ask that what's your concern, like what is the thing that is concerning you so far. So after doing that, you will go for the investigations and you will say that okay, I would like to check you, and always start with the basic things rather than going for the advanced investigations. Always start with that I would like to check your vitals. And when you say vitals, you need to verbalize that I would like to check your blood pressure, I would like to check your respiratory rate and your pulse rate and your temperature. So after that, you will say that I would like to do your general physical examination. Rather than saying general physical examination, uh, you should say that I would like to check you from head to toe, because that's something that the patient will understand and it's not a medical jargon. And after checking from head to toe, you will verbalize the examination on the specific part of the body that you want to do. So in this case, as it is chest pain, you will say that I would like to examine your chest. So, after verbalizing that you want to examine the chest, you will start verbalizing all the labs. But please try to keep, take pauses rather than sounding monotonous or robotic. And it seems like that you have memorized some script and that's why you are verbalizing everything in one row. So try to take pauses, like I would like to check your vitals. That includes your heart rate, your BP, your pulse rate, and your temperature. Also, I would like to check you from head to toe and examine your chest. And with that, I would like to do, or I would like to send few initial baselines. That includes your full blood count, your liver function test, your renal function test. Always remember that full blood count, liver function, and renal function test, they come in the category of the baselines, and then the special blood test that you want to do. So in the chest pain scenario, you always want to order one ECG and a chest X-ray. So being a safe doctor, these two things, regardless what diagnosis you have made, even if it's costochondritis, even if it's pericarditis, you always have to do one ECG and a chest X-ray. And with that, you will say that I would like to send you cardiac enzymes. What if this myocardial infarction is not the one that you can recognize in the ECG? Maybe the ECG is normal and there is no ST elevation there. So you want to cover that area and you want to send your cardiac enzymes, that includes your trop INT, and you want to see if this is non-ST elevated myocardial infarction. Now coming to the part that how you will make diagnosis, I have simplified it into the into these 6 points. And number one, when you do the Socrates that I told you earlier, that whenever there is a history of pain, you will always be asking Socrates question, and whenever there is symptom apart from the pain, you will always be doing Odipara. And I told you in detail that what is Socrates. So when the patient tells you that this chest pain onset was sudden and it started like 2 hours ago or maybe 3 hours ago, so the history is short and it is sudden, and patient is telling you that the pain is central or pain is more on my left side, and it's maybe radiating to jaw or maybe radiating to left arm. So all those things indicating that the patient is having acute coronary syndrome or myocardial infarction. So like you have to identify these things in your Socrates in your first golden 1 minute. that okay, my patient is having a history of only 2 to 3 hours, my patient is having sudden onset and it's kind of heavy or crushing in nature, and it's going or radiating to jaw or left arm as well. So you know that okay, there is no second option, it's ACS, acute coronary syndrome, or myocardial infarction. Now, number second, if the patient tells you, no, my chest pain is like for 2 to 3 days, maybe, or maybe 4 to 5 days, and it increases when I'm lying down and it decreases when I'm leaning forward. So there are two, there is aggravating factor, there is a relieving factor. So in Socrates, you will be identifying those one aggravating factor, that is on lying down, and the relieving when the patient is bending forward. And plus, when you will ask the patient like, how's your health overall, or did you have any fever or flu, that I told you earlier, that you will ask in the history, patient will be giving you history of upper respiratory tract infection like fever or flu symptoms 1 week back or 2 week back. So collectively, when you know these things in the history, you will know the diagnosis, and that is pericarditis. So pericarditis is something that is the inflammation of the heart, and it comes after the after some kind of viral flu infection. And now this is there is there is a relieving factor on posture change, and there is aggravating factor on posture change. You know that pericarditis, it's not heart attack, but to be on safe side, still you're ordering one ECG and your chest X-ray. Number three, if the chest pain is there, but it's not something that started 2 to 3 hours back, and it's not crushing in nature, but this chest pain has been there for last 1 month maybe, or for the 2 months maybe, and that increases when the patient is, there is some kind of exertion, when patient is climbing stairs maybe. But this chest pain, the patient will tell you that, okay, doctor, this chest pain improves when I rest. So you know that on resting down, this pain is being relieved, and on climbing stairs or on physical exertion, this pain is increasing. This could be the symptom of angina. Angina and myocardial infarction are two separate things. I will be telling you after completing these 6 points. Then you have chest pain, and patient tells you that okay, there is a history of trauma. As I told you, the associated set of questions that you need to ask in chest pain, one of the question was you need to ask if there has been any injury to the chest recently. So a patient will tell you like, okay doctor, I was cycling, or maybe I was doing gym and I got hurt there. So now you know that there is a history of trauma, and this pain is simpler. This pain has been there for the last 1 week, but there is no upper respiratory tract infection, there is no fever, there is no pain radiating to the jaw or like heavy in nature or crushing in nature. Now you know that okay, it's simple costochondritis that might be causing this kind of chest pain. And when you will be verbalizing that I would like to examine your chest, examiner will tell you that there is a tenderness on the chest area. So now you will confirm your diagnosis after this examination part, and you will tell the patient, okay, it's costochondritis, and it is because you hurt yourself recently in the last 1 week, or maybe in 2 weeks, and now that's causing this kind of pain. I will be discussing the management for each of the diagnoses separately. First, we need to know that how to make a diagnosis by chest pain symptom. Then, coming to the fifth part, and this is if you have a patient who is telling you that I'm having this chest pain, which is burning in nature, and there is also a rash on the chest. Now, rash is also one of the questions that I told you earlier in the video, that out of those 8 questions you need to ask, one question is that you need to ask that if there is any rash in any part of the body, and patient will tell you, yeah doctor, there is a rash on my chest. It could be on the right side, it could be on the left side. So now you know that my patient is having herpes zoster infection, or you call it shingles. Then number 6, if patient presented with a scenario where there is a chest pain which is for the last 12 hours or within the last 24 hours, not more than that, and with that patient is short of breath and ECG is normal, cardiac enzymes are normal, but the patient traveled recently in a long flight, or patient is pregnant, patient is female and patient is pregnant, or my patient took a long flight like 12 hours flight or 14 hours flight, then what could it be? It could be pulmonary embolism. So according to the symptoms that patient will be telling you, you will pick those clues, and then in the end you will make one diagnosis. If you're not a good active listener, then you will not be able to make a right diagnosis. You need to listen to every point that patient is telling you. That actor who is sitting there in the plab exam is there to help you. So you need to pick these small clues and you will make your diagnosis definitely in the end. So once you know that this is my diagnosis, you have verbalized your examination, you have verbalized your routine blood test, and you have asked the patient the idea and the concern. Now coming to the management part, you can finish the ice part, and you can set that before I tell you that what we can do for you in this condition, or how we are going to treat you in this condition. Is there any certain expectation from today's consultation? Is there anything particularly that you're looking for today, and I should emphasize more on that? So now you know that in what direction patient want to talk to you. So you will be emphasizing on that part in the management more than the other points. Coming to the management part, once you have made the diagnosis that it is acute coronary syndrome or it is myocardial infarction, so what's the management for these two? So acute coronary syndrome, myocardial infarction is the same thing. Now, acute coronary syndrome is divided into two parts. One, acute coronary syndrome either could be the unstable angina, or acute coronary syndrome could be non-ST elevated MI. So now you need to identify either my patient is having unstable angina or my patient is having non-ST elevated MI. Non-ST elevated MI is the one where ECG is normal and TROP I is raised, and now you know that there is MI but there is no ST change on ECG, so this is non-ST elevated MI. Uh, Now coming to the part to the management for the unstable angina, you will prescribe these 5 things that I have written in the notes, and those will be, you will tell the patient that I need to give you blood thinners, because in your case there has been a blockage in one of your vessels that is causing this kind of pain and shortness of breath. So we will be putting you on blood thinners, and those will be aspirin and clopidogrel. Now, recent guidelines say that ticagrelor is more effective than clopidogrel. So it's your choice, either you want to go with the clopidogrel or ticagrelor. But these two medications, either clopidogrel or ticagrelor, you will not give if there is a risk of massive bleeding in that patient. And how can you assess the risk of bleeding? By seeing the APTT levels of the patient. And then coming to the part, you will give the patient low molecular weight heparin, you will give patient sublingual nitroglycerin, and number 3, you will give patient a beta blocker, and the patient is asthmatic, then you can go for the calcium channel blocker. That is a second option for you. But most important of all, if you are verbalizing this management, you need to tell the patient that I will inform my senior ASAP, and he will come and review and confirm the diagnosis. We will admit you, we will observe you. Once you have involved your senior, once you have admitted the patient and told the patient that you need to be observed there, then you will be telling the patient that we are going to give you some medications that will thin your blood, that will give support to your heart to pump efficiently, and there will be some medication that will be relieving your pain. So rather than saying all those fancy words, all those medications, try to be more simpler. If patient is specific which medication, then you can verbalize all these medications that I have told you. But in most of the cases, you need to be on more simpler side while you are verbalizing the management. Now, after telling this management, coming to the part where there is ST elevated MI. Acute coronary syndrome is something that is divided into non-ST elevated MI and unstable angina. We call it minor heart attack or mini heart attack, but ST elevated MI is the one that we call major heart attack, and it's a real medical emergency, and you need to refer your patient as soon as possible if the patient was in a GP setting. Always remember that when you enter into your cubicle, you have read the scenario, you should know that in what kind of setting what kind of sitting I'm there, and accordingly you have to manage the patient. Like if you're sitting in the GP and you're telling the patient we are going to keep you here and observing you and calling my senior, that is not going to make sense. Now the examiner knows that you know everything, but you are so scripted, didn't notice that you were in the GP setting. So in the GP setting, you will say, as we are in the GP setting and we do not have all the facilities here to deal with the medical emergencies. That's why I'm calling the ambulance, and I'm sending you to tertiary care hospital, or I'm sending you to the emergency uh, of the hospital, where there will be cardiologists, where there will be seniors who can deal with this emergency, and I'm going to call and inform that hospital before you arrive there. So now they know that you know what kind of setting you are sitting in, and you are a safe doctor, and you are informing the next hospital where you are referring your patient. And also tell the patient that meanwhile I am going to give you pills or medications for now till you reach their hospital. So now the examiner know that you know about the loading in the case of unstable angina or MI, and that is you will be giving that patient nitroglycerine, and you will be giving that patient aspirin. That is really important. If you did that, if you know that your setting was GP and you referred your patient, you will be getting really good marks in your station. Coming to the ST elevated MI, the protocol is the same. You need to know what kind of setting it was, whether it was a GP or a hospital, whether there is a cardiologist or not. And then if it is a hospital, luckily, you will say that, okay, we are going to admit you, and you are having a heart attack right now. And is there anyone who you want to call who can watch you in the hospital? And I'm going to involve my senior as soon as possible. They will come and they will check you. I'm going to call cardiologist. Meanwhile, we are going to give you this pill that you need to chew, and that pill will be aspirin 300 mg. After giving the aspirin 300 mg, there is a major decision that you need to make. You need to know that if there is a cath lab in my hospital, or if there is no cath lab in my hospital. Cath lab is where PCI is being done, or cabbage is being done in major heart attacks. So if you know that there is a cath lab in my setting, you will keep the patient in your setting, and you will involve the cardiologist, who will do either PCI or he will do the cabbage. PCI is something that is percutaneous coronary intervention, that is being done in the patient who has got only like 2 vessels blockage. If this is a triple vessel disease, cardiologist will go with cabbage, but these are technical terms that you don't need to narrate in the plab 2. And if you know that in the setting you don't have any cath lab, then you will go with 2 options. Either is there any cath lab in the town where the patient can reach within the 2 hours? If the patient can reach within 2 hours to that facility, refer the patient as soon as possible. But if you are sitting in a setting where there is no cath lab and patient cannot reach within the 2 hours, then you need to keep patient to yourself and admit and give fibrinolytic agents in IV form. You can give IV heparin, and you will adjust the dose and monitor APTT levels. Again, these are advancing. You just need to verbalize that, okay, we don't have cath lab and we cannot refer you to the cath lab within the 2 hours. That's why we need to keep you here in the hospital, and meanwhile we will give you alternative drugs to prevent any kind of more blockage into your vessels. So sometimes there is a scenario where the patient is there, patient had MI 2 weeks back, and now the patient is there, and you need to counsel patient about the medications, or the patient was having heart attack 3 days back. Now the patient is stable and he needs to go home, and now you are the one who is going to discharge that patient. Now you need to tell the patient about the medications, and you have to do the counseling related to the lifestyle, so that the patient don't have second attack or episode in the future concerning MI. If you have got that station where you need to talk about the long-term management, you will be telling these things, that we are going to discharge you with some medications that you need to take regular, lifelong. If you will not be taking those medications lifelong, then there is a great chance that you will have a second or third heart attack. And we don't want that for you, and I know that you don't want that for yourself. Even for that, you need to take your blood thinners regularly. That will be one low dose aspirin and ticagrelor or clopidogrel. You will tell that there is one medication that is there to provide to strengthen your heart, or to provide strength to your heart, and that is the beta blocker. and you will tell the patient that it happened because there was a bad cholesterol in your body. That's why we are going to give you statins that will be helping you to reduce the bad cholesterol in your body. Then you will tell the patient that there is one medication that is we called ACE inhibitors that will be reducing the blood pressure in your body, because high blood pressure can lead to major heart attacks. And you will tell the patient you need to adapt few lifestyle changes. I will discuss in detail about those lifestyle changes in session maybe 5 or 6, where I will tell you that what kind of diet, what kind of exercise, and he needs to stop smoking, he needs to stop alcohol. We will discuss all those things in very much detail. Coming to the other part, that is pericarditis. So if you have made your diagnosis that okay, my patient has got pericarditis, first of all you need to explain to the patient that okay, you have a condition that we call pericarditis. There is a layer that is covering your heart, we call it pericardium. That layer has become swollen, or that layer has become inflamed. It usually happens when the patient is having any kind of viral flu or fever in the last 1 or 2 weeks. Don't worry, this is something that is curable and it's not dangerous. We will only advise to take painkillers. We will prescribe some painkillers that you might be taking. It will take 3 to 4 weeks to have a complete recovery. And if your pain is not subsiding in the next 14 days, we might change your painkillers and we might give you something strong. And if your pain is not subsiding, then we may need to consider steroids after taking a review from a senior. Okay, so these are the steps that you will be taking in pericarditis. Coming to the costochondritis part, it's really simple. You need to tell the patient that it's because of the trauma that you hurt yourself recently. That's why you are having this inflammation over your ribs, and that is causing costochondritis. Sometimes it could be really bad and it could sound like you are having a heart attack, but you're not. That's not the case. You just need to lie down. You just need to take deep breaths. You need to take your painkillers regularly till this condition resolves. It can take 2 to 4 weeks. And with that, I will advise you not to play any kind of contact sports and not to do heavy gym, but you can do lighter exercises there. And with that, you will be doing safety netting. Any case, any station in the plab 2, all those 16 stations, you need to do safety netting. Don't forget that. According to the symptom, you need to do safety netting. In chest pain, you need to tell the patient that if this pain is going to your jaw or your left arm, or you are not able to breathe, then you just need to call 999 and come back to us. In every scenario, you will be doing safety netting in that. Please do not forget that. Now, if we talk about the management of herpes zoster, herpes zoster is a viral infection. So basically, patient has developed a rash over the chest, and it is because of some viral infection. And this herpes zoster is really painful. You need to know about that. So you need to be empathetic towards your patient. Do not tell the patient it's a rash, it will go away, oh, don't worry and all. You should know that herpes zoster is a really painful dermatological condition, and you need to offer support accordingly. You need to tell the patient, I cannot imagine the pain you might be having right now. I know that herpes zoster is one of a very painful condition, and I understand your anxiety, but I'm here to help you. We will be giving you some medications that will help you in the recovery process, and we will be giving you some painkillers so that you can resume your daily life activities as soon as possible. Okay. Herpes zoster, you can give oral antiviral because they work more effectively rather than the topical antivirals. You will give something for the pain control, and you will involve your senior to have a review on the herpes zoster. There's some advices that you will be giving the patient that will help him in the treatment part. You need to tell the patient that this rash is kind of thing that can spread to another person. So you need to try to tell every family member that they don't touch this rash, and please keep this rash clean, keep this rash dry, try to wear loose clothing. So because if there is some kind of cloth like silk and all, that can actually irritate your chest and it will increase your pain. So please try to have loose and soft clothing. And please try to be away from the older patients and from the sick patients, from the immunocompromised cancer patients, from the pregnant females, from the children, because herpes zoster can affect them in a really bad way. Plus, if the patient asks you that how much time it will take for it to recover, always say that it can take 3 to 4 weeks. So, if you can see the resemblance, pericarditis is resolving in 3 to 4 weeks, costochondritis can take 2 to 4 weeks, herpes zoster can as well take 4 weeks. So, it's easy to remember that in chest pain scenario, you can say safely that it will take 4 weeks to recover, and then again do the safety netting in the herpes zoster part as well. Coming to the pulmonary embolism, this is the last scenario. This is pulmonary embolism is really not high yield when it comes to the chest pain scenario, but you should be prepared for that. Pulmonary embolism patient, you always need to admit the patient. You need to tell the patient that we need to admit you, we need to observe you, we need to call a senior, and we are going to give you oxygen 100% if it is needed. If the patient is maintaining the saturation, there is no need to say that. And then when you admit the patient and if you have given the oxygen that was needed 100%, you will obtain an IV access from the patient, and you will give analgesia like morphine in the case of a severe chest pain. Morphine is the drug of the choice in pulmonary embolism. And then there is a score that we call well score. Well score is to rule out that if the patient is a strong candidate for the pulmonary embolism or not, and with that you can order a CT pulmonary angiogram in the pulmonary embolism patient to rule out or to confirm your diagnosis, because CTPA is a gold standard investigation in pulmonary embolism. And you will tell the patient that we will be putting you on a continuous infusion of the low molecular weight heparin, so that there is no other, to make sure that there is no other embolus in the chest that might block your lungs. And then you will tell that patient that I will be involving my seniors in the very first step. Now the second station is tiredness. Tiredness is again a symptom, and there could be many diagnoses related to tiredness. I told you that whenever there is a symptom related to pain, you always do Socrates. But whenever there is other symptom, like if the patient tells you that, doctor, I feel tired, that's why I'm here today, you need to do OD para. And what is OD para? You need to ask the patient that when, why, and how. That is the onset that you need to ask. So onset is like when did it started, and how it started, when was the first time that you started noticing that it's happening to you. And then D is for the duration, again, for how long, and when there is one episode of tiredness, how long it lasts there. I is the intensity, that if you can tell how much it is affecting your life. And P is progression, that if it is the same when it started 6 months back, or is it it is something that is increasing or getting worse day by day. And then A is for the aggravating, like if there is there anything that makes your tiredness more worse for you. And then R is relieving, is there anything that makes your tiredness better for you. And the last A is for anything else, is there anything else that you want to tell me. So you will ask about how, when, and how it started, when it started, how long it lasts when it starts, is it affecting your life, is it getting worse, and is there anything that makes your pain better, is there anything that makes your pain worse or tiredness worse, and is there anything else that you want to tell me. After doing this OD para you will be doing in every other scenario. There only in the pain you will not be doing that. Then coming to the, if there is a history when there is a fall from height, you won't ask OD para. If there has been a fit or seizure, you will not do OD para. I will tell you how to take a history for a fall or for a seizure or jerky movement. But apart from that, every other scenario is about OD para. Now, in the tiredness, what kind of associated symptoms you should ask? These set of questions you will never miss in the tiredness. And those are like, do you feel short of breath? Do you feel that you have lost some weight or you have gained some weight? And do you feel cold when others are not? And how is your mood? Can you scale your mood on a scale of 1 to 10? 1 being the least happy and 10 being the most happy. Then if there is been any, are you going to the loo more often these days? Are you feeling more hungry these days? Do you feel your mouth is always dry? And how is your sleep? And do you feel that you keep taking naps during the day? I will tell you that why you should ask these all 10 to 11 questions in the station of tiredness. And it will make sense to you that why we are asking these questions, because we are trying to rule out our diagnosis. You are asking these questions because you have different differential diagnoses in your mind regarding tiredness. And two I have written above that you can see is tingling and numbness. You should ask, like, if you do you feel that there is a tingling or numbness in your fingers of your feet or your toes. Then after asking this set of questions in the tiredness station, you will do maftosa. I told you that it's the same in every medicine, eye or ENT station. You need to ask about the medications, allergies, family history, traveling history, occupation history, social history, and last A is if there is anything else that one patient wants to tell you before you end this consultation. So, like, you have done ODPARA, you have asked this 10 to 11 set of questions, you have done your maftosa. Now you will ask if the patient has got any idea why she is feeling tired. Do you have any idea what might be causing it? Now you know that if the patient is thinking worse of the worst scenario, or the patient is thinking something really simpler. And what is the thing that concerns you the most regarding this? And patient will tell you, it is affecting my job, or it is affecting my relationship with the family, my relationship with my husband, or I'm unable to complete my task, or something like that. So you know that in what direction you have to address the patient's concern, and that is the main goal. You're always in the plab 2, you will not manage the patient, you will manage the patient concern, because that's the thing that will help you to pass your exam. After that investigations part, you will come after doing, ideas and concerns. Rather than asking the expectation, come to the investigation part, and you verbalize the things that I told you in the chest pain. You will verbalize things in a really nice way. Okay. Thank you for answering all those questions for me, Mrs. XYZ. Now it's the time that I would like to check your vitals. That includes your heart rate, blood pressure, your temperature, and your pulse rate and BP. And then you should include blood sugar levels also in this one. I will tell you why. And then I would like to check you from head to toe. I would like to send few routine blood tests to see if everything is okay. And I would like to send few special blood tests that includes your thyroid function test. After doing that, coming to the diagnosis part, now I'm telling you different differential diagnosis regarding tiredness. That will make more sense to you, that why we are asking all these questions and why we are ordering these blood tests and all. So number one, if the patient tells you in the scenario, doctor, I feel tired, and with that, when you ask the patient, like, do you feel short of breath and did you lose some weight or do you feel dizzy, patient will tell you, yes, I do feel tired, I feel dizzy, I feel short of breath when I take few steps or when I walk for only half a mile, and I feel that I cannot breathe properly. And if she's a female, you always do 4 P's in the history. What are those 4 P's? You always ask every female that how are the periods, if the patient is taking any pills, or patient is having pap smear regularly or not, and the patient is pregnant or not. So pregnancy, pills, pap smear, and periods. These are the 4 P's you will always rule out in every female. And if it is a station that belongs to tiredness presenting complaint, you will be asking if the patient has got heavy periods. And how is her oral intake, if she is taking proper diet or not, if she is vegan and she's not taking meat, maybe something like that. So now it makes sense to you that, okay, my patient is short of breath, my patient is dizzy, my patient has got heavy periods, and she's bleeding a lot every month, and my patient is tired, so it could be anemia, right? If you would not have asked the questions like shortness of breath and dizzy and heavy periods, you will never know that the patient could have anemia, and you cannot justify your diagnosis. Number two, if patient tells you, no doctor, I feel tired for the last 6 months, maybe the history will be more prolonged, and I feel cold when others are not, I am gaining weight, I'm having constipation, or I am having bad mood, you will know that my patient has a more chance to have hypothyroidism, right? Number three, if your patient tells you, no doctor, I'm tired, but apart from that, I do not have any dizziness or cold intolerance or any weight gain, I'm just tired and I'm having low mood. Patient will score the mood on the scale of 1 to 10 like 4 out of 10 or 5 out of 10. So it could be depression. Number 4, if patient is a guy who is a lorry driver or a taxi driver and he's obese, his BMI is more, and he's tired and sleeps all day, but he sleeps in the day, and patient is snoring loud, and patient is obese, you know that my patient is could be a classical case of obstructive sleep apnea. Number 5, it could be diabetes mellitus. So now coming to the symptoms that I told you that you need to ask in tiredness, I told you that you need to ask shortness of breath, you need to ask about weight, you need to ask about tingling numbness, because it will tell you that the patient has anemia or not. I told you that always ask weight gain and cold intolerance. It will tell you about hypothyroidism. I told you ask about the mood because it will give you a hint regarding depression. I told you that always ask about urination and appetite. If the patient tells you I'm going to the loo more often, I'm eating more, that means patient can have diabetes mellitus, because patient is having polyuria, polyphagia. And if patient tells you, no doctor, I take multiple naps in a day, and I'm a lorry driver, and he's obese, when you see that patient, or you do the BMI of that patient, now you know that it could be obstructive sleep apnea. So these are the must questions, these are the must associated questions or set of questions in the tiredness station that you won't miss at any cost. Okay. So after making your diagnosis, I have written all those 5 diagnoses, the top 5 diagnoses. There could be multiple other diagnoses regarding tiredness, but these are the top 5 that come in the plab 2. Now you will do the management accordingly. For example, it is the station of the anemia. Your examiner will tell you, when you will say that I would like to do your routine blood test, that includes your full blood count, your liver function test, and your renal function test. And examiner will hand over to you a sheet where it will be written that patient HB is maybe 10 or maybe patient 9, and MCV and MCH is increased. Now you know my patient has got anemia, but what kind of anemia? If the MCV and MCH are increased, that means your patient has got vitamin B12 or macrocytic anemia. But if the HB is decreased, but with that MCV and MCH are also decreased, that means your patient is having microcytic anemia, and then it could be iron deficiency anemia. So act accordingly after seeing the reports. The most common station that come in plab 2 is vitamin B12 one. And vitamin B12 patient will give you a positive history about the tingling and numbness sensations. He or she will tell you that, yes doctor, I get this tingling or numbness in my fingers or toes. And MCV, MCH is increased, HP is decreased. You know that it's vitamin B12 deficiency. You will tell the patient that, okay, I'm suspecting that your blood is weak. In UK, about anemia, you tell that your blood is weak rather than telling that you have anemia. And the kind of anemia you are having is particularly concerning vitamin B12 levels in your body, and your body is maybe unable to absorb B12, or it could be the chance that you're not eating enough red meat. Maybe your patient could be vegan. That's why patient is not having a proper source of vitamin B12. So how you will manage the vitamin B12? You need to tell the patient that we need to and give you injections that will contain vitamin B12, and that injections will be given every other day for the next 2 weeks. So for the next 2 weeks, the patient will have 1 injection every other day. And if the patient is vegan, that means that the patient has got no problem with the absorption of vitamin B12, but the patient is not having enough intake of vitamin B12. So you will tell the patient, okay, you're vegan, you cannot eat meat. What alternative that we might offer you is we will give you oral tablets that will contain vitamin B12, and you have to take those vitamin B12 tablets for long term. And if the patient is not vegan and you have prescribed the patient that you will be having injections every other day, you will tell the patient there are some diets that might help you in increasing your vitamin B12 levels, and those diets can be dairy products like your eggs, meats and salmon, And after giving those injections, you will repeat these vitamin B12 levels, and you will repeat the test after 2 weeks, and then you also repeat this test after 8 weeks. So you are repeating the test for 2 times, once the treatment is completed, at 2 weeks, and once at the one at the 8 weeks. So this is a protocol that NHS follows for vitamin B12 levels. Now coming to the hypothyroidism part. So you have done the thyroid function test. If you have seen that patient thyroid function tests are suggestive of hypothyroidism, that will be that increased TSH and decreased T3 and T4. You will explain patient that thyroid gland is something that is located in front of our neck, close to our windpipe, and it is producing some hormones that are regulating our body temperature, our mood, and our weight. So in your case, that hormone is not sufficient in your body, or thyroid is not producing enough hormone. That's why you're having hypothyroidism, and we need to give you some medication that contain that hormone, and we can give that hormone artificially into your body. So you will explain it really nice. You need to take pauses. For example, I will try to explain it. So you will tell Mrs. XYZ, in your case, it seems like that you are having a condition we call hypothyroidism. Now take a pause and ask, do you have any idea what is hypothyroidism? Patient will say yes or no maybe. If patient says yes, and then you can ask the idea that patient might have about this. If patient says no, that is in the most of the cases patient will say no. You will say, okay, I will try to explain it. There is a gland we call thyroid gland, and it is in front of our neck, close to our windpipe. So Mrs. XYZ, you need to know that that gland is really important in our body because it is producing really important hormones that are regulating our periods, that are regulating our weight changes, our appetite, our temperature. In your case, it looks like the hormones are not producing enough in your body, and that's why this condition is hypothyroidism, and we need to give you some medication so that you can have those hormones artificially in your body. Do you understand that so far? Patient says yes. Okay, so I will tell you that pill that we will give you, you might need to take lifelong, and we call that pill levothyroxine. Do you get that, Mrs. XYZ? And patient will tell you yes. Then you need to tell the patient, we need to increase or decrease the dose of levothyroxine. Accordingly, we will keep checking your thyroid function test regularly, maybe after 15 days, and we will keep changing the doses in the first month. But once we have established the dose, then you need to take that dose for a long term. And then you need to tell the patient, but Mrs. XYZ, that pill can take 7 to 10 days to work for you, because it's been a long time your body was not producing the hormone. It can take 7 to 10 days to make a change in your body, into your symptoms. So I will advise you to be patient in this process, and after 7 to 10 days you will observe few positive changes. Okay. And if the patient has presented with a low mood, because depression and hypothyroidism are interlinked and they have a very common association, you will offer that patient support. You will do two things. One, you need to ask the patient how you're coping up with your low mood. I know it might be a difficult phase for you. Is there anyone else back in your home who can offer you a support? And then you will offer a psychiatrist. Mrs. XYZ, I was thinking that with that pill, you should take some sessions from a psychiatrist. I can make a referral, and we call it a talking therapy or cognitive behavior therapy, where you can vent out your feelings and it might help you in the process to feel better. How does that sound to you? So, like that, you have covered the medicine part, you have made your diagnosis, you have offered empathy, support, and you have involved a psychiatrist. Now, it's a complete package that they might be looking in a junior doctor. And then you can tell the patient, if the patient is obese, obviously hypothyroidism is related with obesity, metabolic rate is low, you can tell patient, I will advise you to do exercise or to walk regularly. I can help you to join an exercise training program. And science has proven that after the people who walk for 40 minutes, there are happy hormones in their body that are being released, so it can help you to lighten your mood. Okay. After this share of information, you will tell patient that we need to have your regular follow-ups annually. Once we have established the dose, that doesn't mean that you will not be coming to the hospital. You need to come to the hospital annually or maybe 6 months as per the advice of doctor. And you will tell the patient, I know that I wasn't able to cover all the details, that's why I'm going to give you a leaflets that will provide you information regarding your regarding your health condition. And then you can do the safety netting. If at any point you feel that you are having tremors, you are vomiting, you are having abdominal pain, you are having high grade fever, just call 999 and come back to us. Why we are doing this kind of safety netting? Because levothyroxine can go into higher doses and it can cause hyperthyroidism and it can cause hyperthyroid crisis, and we do not want that in patient. So you will tell the patient about abdominal pain, tremors and diarrhea. Those are the symptoms for the hyperthyroid crisis, and with the safety netting your station will be complete. And now coming, if your diagnosis is obstructive sleep apnea, obstructive sleep apnea has 2 to 3 parts. One, how to diagnose obstructive sleep apnea. You need to do few special tests. Initial test, you will tell the patient that we will do a pulse oximetry that will measure oxygen levels into your blood. And how we do the pulse oximetry? Basically, there is a device that we call pulse oximeter that we place onto your finger, and it will measure oxygen levels into your blood. But the gold standard investigation for obstructive sleep apnea is polysomnography. It is an overnight study that we do in a patient, and we prefer to do it in the clinic or hospital setting rather than doing it at home. So, in overnight polysomnography in the hospital, we will be observing your sleep pattern, how many times you were asleep, and then wakefulness cycle, and how were the brain waves during that, and how were your muscle movements, your eye movements, and then counting the total number of your sleep and counting total number of your wakefulness, that how many times you were awake and how many times you were sleeping. Then we will collect that index, and then we will according to the formula we will make a score of your AHI index, and it will help us to make a diagnosis of obstructive sleep apnea. Now you cannot tell these technical terms like AHI index and all to the patient. You will just verbalize that I would like to do a study that is being done in the hospital or clinic overnight, and we call it polysomnography, where we observe your sleep and wakefulness cycles and your brain waves and your eye movements to see if you are having obstructive sleep apnea according to the score. And if your diagnosis being confirmed that you are a case of obstructive sleep apnea, we will advise you few things. One of those is that you might need to have a CPAP at your home, and CPAP is one of the gold standard treatment for obstructive sleep apnea. And there are some sleep hygiene changes that you can make while sleeping, and that is like sleep in quiet environment. Your bed end should be raised. You can sleep on 2 pillows and try to sleep left laterally rather than sleeping straight. It can help you with your symptoms. Okay. And please, if the patient will always be obese in this case, you will need to tell the patient that you need to lose weight, because your obesity is causing the obstructive sleep apnea. Once you have lost the weight, it will improve your symptoms. And always make a referral to sleep clinics in obstructive sleep apnea, and then there are some OSA where we will offer the surgery, but again we will need to have a review from a ENT surgeon or from our senior, who will tell if the surgery is needed or not. So you have told about losing weight, CPAP, and surgery, and now you have to make a referral to sleep clinic. Now you have to inform the DVLA. obstructive sleep apnea station and you have not informed DVLA or you have not talked about the DVLA, there is a chance that you might fail the station, because it is an important aspect in NHS. They are looking for that, you know, that if the patient is having OSN, the patient is a taxi driver or patient is a lorry driver who keeps driving on regular basis, it could be dangerous for an obstructive sleep apnea patient. So you need to tell the patient that you need to inform DVLA. And if the patient says, doctor, I cannot tell DVLA, they will snatch my license or they will stop me from driving and my livelihood depends on that. So how will you tackle that? So you will tell the patient, well, Mr. XYZ, I understand that your livelihood depends on that, and it's too much to ask. But uh, I know that you don't want to put yourself into a trouble, because in this condition that you are having right now, there is a great chance that there is a great chance to have an accident. And if you tell DVLA that, or you tell the sleep clinics that your livelihood depends on driving, they will speed up your process and they will make sure that that you get the treatment for obstructive sleep apnea as soon as possible so that you can resume your driving. Do you get that? And you can always apply for the benefits from the government if you think that you are not able to resume your driving and you're not earning enough, or sometimes we can link you with occupational therapist who can change your occupation according to your condition. So you will be always giving alternative solutions and do not compromise on not informing the DVLA, because that's the real part. You need to inform the DVLA. If the patient is not, then you have to. But always try to approach in a positive manner, in a soft manner, where you will need to convince the patient uh, that you need to tell DVLA, rather than saying, okay, you will not tell, I will tell the DVLA. That sounds rude, and that is not something that we call constructive approach. You need to tell the patient about the dangerous implications that can come if not telling the DVLA. Okay. Now we have the third station, that is called polymyalgia rheumatica. You can write in your notes that it is a very high yield station. Out of all the stations that we are discussing, polymyalgia rheumatica comes every other day in the plab 2. So if there are five tests being held in 1 week, always there are two times there will be polymyalgia rheumatica you will be seeing in the stations. Polymyalgia rheumatica can present with multiple scenarios that I will be telling you. Sometimes they will tell you straightforward that this is the case of polymyalgia rheumatica and the patient is here uh, for a review, and the patient don't want to take steroids. Sometimes they will just give you a scenario with a symptom, and then you need to make a diagnosis and you need to tell that what polymyalgia rheumatica.